Well, good morning. It's wonderful to see so many folks in the room today. And then I see we have a lot of folks online as well. So really appreciate everybody being here. For those who don't know me, I'm Erin Finley. I'm a professor in the Departments of Medicine and Psychiatry and Behavioral Sciences and director of the Dissemination and Implementation Science Consultation Core here in the REACH Center. And I want to start by thanking the Division of General Internal Medicine for co-sponsoring today's grand round with us. We appreciate that collaboration very much. It is a great pleasure to introduce today Dr. Bijal Balasubramanian, who is a distinguished expert in the field of implementation science. She's trained in internal and hospital medicine and also holds a PhD in epidemiology from Rutgers. She's currently the Rockwell Distinguished Chair in Society of Health and tenured professor and regional dean at the UT Health Houston School of Public Health in Dallas. She is the director of the NCI Cancer Prevention and Control Training Program at UT Health Houston, as well as founding co-director of the Institute for Implementation Science there. She's authored more than 100 publications and is currently principal investigator on active grants totaling more than $8 million, primarily related to research and training in implementation science and cancer prevention and control. If you're inspired by her talk to pursue more research or training in implementation science, and if you come to our core for consultation and support, one of the things that we will probably do is connect you with the terrific training and workshop opportunities offered by her institute. They have really become an invaluable resource, and we're so appreciative of what they've created and making available for building our capacity in this area. So thank you so much for being here, and please join me in welcoming Dr. Balasubramanian.
Thank you, Dr. Finley. Thank you so much for the kind words. And yeah, I'm really excited to see everybody here and talk a little bit about implementation science. But really, one of the things we tried to do with grand rounds over the last 2 weeks was connect the dots, perhaps Olympic style, take the baton here from Dr. Savat. On the clinical practice guidelines and U.S. Preventive Services Task Force guidelines that you talked about last week. And so we decided we'd kind of connect there and say, well, there are all these practice guidelines, and what happens after that? How do we implement them? How do we implement them consistently? And implementation science as a sort of relatively newer field helps us think about how to approach that. And so that's kind of how our two talks came about as a two-part series, if you might, and hopefully over the next few minutes, 40 minutes or so, we can delve into that. As Dr. Finley said a little bit about the UT Health Houston Institute for Implementation Science, I put the link in here for some resources, especially recordings of past seminar series that give you just easy access if you're interested in implementation science as a field. Okay, should I go with the... Yeah, thanks. I do not have any disclosures, but I do want to acknowledge my co-director at the Institute, Maria Fernandez, for some slides that I stole from her, and also all of the co-investigators and staff of the CDC Colorectal Cancer Control Program that I'm going to talk about a little bit more in detail. So if nothing at all, I hope to achieve 3 goals over the next few minutes, 30 to 40 minutes. I think I want to really illuminate this black box of what is implementation and all of the factors that influence adherence to clinical practice guidelines. Give a little primer on implementation science for, I say clinical professional, but it's really a 101. I haven't gone into too much detail. And then I really want to spend the bulk of my time providing an illustrative example of applying implementation science to increase colorectal cancer screening in FQ8Cs. And this is work that we're doing out of the CDC-funded program. FQ8Cs are federally qualified health centers. And so I'll jump into those things. So Dr. Savad talked about the U.S. Preventive Services Task Force, and they provide evidence-based recommendation on clinical preventive services. And this is sort of the 5 steps of how the recommendations are developed. And all of the clinicians in the room are very familiar with the U.S. Preventive Services Task Force. We use that in our practice all of the time. And these were the 3 that Joel, you spoke about last time: colorectal cancer screening, fall prevention in older adults, and osteoporosis, which is in draft recommendation. I just sort of put it here to not only say, well, these are 3, but there are guidelines for, I believe, at least 80 different conditions and hundreds of guidelines that primary care physicians and physicians in general are juggling in their day-to-day practice. And it's not just one guideline that we're trying to implement, but at a patient level, we're trying to do it at multiple. And so we really need to have some systematic ways to thinking about this. I put this, 2000 study that really looked at how long it takes from research to getting what we know from research into practice, into implementation. And so I won't go into too much detail, but the slide kind of exemplifies that when you start from original research to even going through the publication pathway and get to the point of those reviews and guidelines that inform the U.S. Preventive Services Task Force, it already is up to 13 years of time that has gone through that. And then even more to get it into implementation in practice and widely into practice, into national levels of implementation, where we talk about guideline adherence rates. And it's commonly said that it takes 17 years to turn only 14% of original research to the benefit of patient care. And this is what kind of really attracted me to the field of implementation science, or a practice change, different ways of saying it, because we have a lot of evidence out there that we don't use well. And we invest more into producing more evidence without understanding how to use what we have well into clinical practice. And so I always say that, with family and friends, I do research, but it's not rocket science research. It's painstaking, hard research to get what we know actually works into practice. So implementing clinical practice guidelines consistently in clinical practice is challenging. All the physicians, clinicians in the room know this. They struggle with that. And I wanted to take colorectal cancer screening here as an example. The first time U.S. Preventive Services Task Force put out colorectal cancer screening guidelines was in the mid-1990s. And here are the rates of colorectal cancer screening rate in the U.S. from 2000 to 2021. And in these 21 years, almost 30 years since guidelines came out, we have made slow progress, but we've made progress. But this is how long it's taking to get from a guideline being issued to optimal rates. And we're still not at healthy people 2030 rates, but we're working on it. And in a little bit, in a few slides, I'll go into, these are overall rates, but the disparities that we have in these rates are huge. So we're not making uniform or equitable progress in implementing these guidelines. So I had a couple of slides to kind of wake everybody up and be a little more interactive, but unfortunately the Mentimeter add-in to the PowerPoint is not working. So maybe, since there are folks in the room and I have the chat here, if y'all can take a couple minutes to think about this question in your experience: what factors make it challenging to implement clinical practice guidelines in your practice? That'll be great. I don't think that QR code will work because the Mentimeter is not working. But folks in the room can just speak up, chime in your thoughts. And folks online, if you can just write what factors they are, a couple of words in the chat, I'll try to coordinate that a little bit. So what factors do you think make it challenging to implement clinical practice guidelines? Sorry, time. Time. Yes. Sorry.
Competing priorities.
Competing priorities.
Cost.
Cost.
I think it's hard when they change. For example, with pap smears, I still have older women who want their yearly pap smear, because that's what they sort of were used to in their younger years. So for me, when they change, it can be hard to pivot, get folks to.
It's changing recommendations. You get into this mode, you're practicing, you're familiar with the certain guidelines, the recommendations change, you have to shift again. Yeah. Short clinic visit time is one of the comments. Distrust in the system is another one that showed up here in the chat box. That's right. Yeah, I mean, I think this is great. This is exactly what I was hoping for. It's multifactorial, and many of the factors y'all are bringing up are really factors associated with your organization, with your time, it isn't about the motivation of a clinician to put guidelines into practice. It's things that sometimes even feel out of control for the practicing clinician when they're in the visit. Well, let's do the flip of it. In your experience, what factors make it perhaps easier or are facilitators of implementing guidelines, if there are any? Thoughts? Say that again.
Can I say time again?
Okay, well, the flip of it. Explaining patients the reasons is one in the chat here.
I think picking, starting with the sort of biggest bang for your buck, like the interventions you feel are most important for that given patient, and maybe prioritizing one or two per clinic visit.
Identifying and prioritizing interventions that actually will facilitate the implementation of those guidelines. Yeah, that's a good one. Dr. Savet.
I'd say having the information available.
Having the information available, that's great. And I think that connects with the interventions. If you have something in the EHR where there is an intervention that optimizes the EHR to have that information at the point of care, or in another way, maybe it's an app that you might be using. Yeah.
Intelligence, smartness of your patients, the education of our patients in the schools is very important.
Yeah, health literacy.
Better they ask for these things. That's why education is so important for us as physicians to express the citizens.
Yeah, that's exactly the case. And a few others here: support from management and administration, but time is still a problem. So yeah, you guys really got into it, and I'm very proud of myself that I managed that Mentimeter thing. It would have been cool if you could actually write it, because everybody would have been able to see them. But here's a recent systematic review that was done. Well, actually, it was an overview of systematic reviews and published in BMJ Open that really helped classify all of the factors or determinants implementing clinical practice guidelines. And they fall into these big categories of patient factors, clinician or clinical team factors, guideline factors, institutional environment and resource factors, and political, social, and cultural factors. And many of the comments you all had fit into these categories. And I encourage you to read this, because it's really nice systematic synthesis of so many things that affect the implementation of clinical practice guidelines. And the overview also talks about the facilitators. For example, a facilitative leadership in the administration can make a big difference. Having quality improvement, people who are thinking how to reduce competing demands, competing priorities, and build that into the implementation of guidelines can help. And there's a lot of organizational science and organizational culture kinds of things that get in the way of implementing any innovations, in this case, implementation of clinical. And I don't know how much our clinical and health systems are focused on enhancing organizational culture, enhancing teamwork, and creating workflows that actually leverage teams better. And I think that there's a lot of potential in that space. And this other umbrella review of the literature kind of tried to also quantify which of the barriers and facilitators were most often reported in the literature. And so on the right side, you see the barriers, and the most often reported barriers were individual health professionals factors or clinician factors, such as time and competing priorities. The second were guideline factors, such as guidelines changing and how do you keep up with things. And then incentives and resources for the team. The most common facilitators, on the other hand, were also incentives and resources if they were provided. The flip of it, again, guideline factors and capacity for the change needed for organizational change. So this was also a really nice overview of the literature for practice guidelines in general. So I'm going to shift to this determinants framework. Feels like a little bit of an abrupt shift, but I like this practice change model. In the implementation science literature, this is kind of old. It sometimes doesn't show up from 2004. But this is a model that helps us start to think about what are all the factors that affect when a health system, a clinic, wants to implement something new and pick a guideline or pick a new intervention or a new workflow. And it came from empirical findings. There was an R01 on implementing preventive services delivery that was done in several, I think 36 practices in the Midwest. And based on the evaluation of that intervention, what we found in this was that there are 4 key boxes here, 4 key domains, if you may, that inform implementation and change. The key stakeholders, they are motivation. And this is sort of in the inner setting, meaning in a context, in the clinic, in the practice, in the health system. Are they motivated to do this? Is there, is there buy-in? Are the leadership facilitative in wanting to do that? And then similarly, do they have the resources to make the change? And both kind of have to be present, because if that doesn't happen, then, well, you may be motivated, but you don't have the resources, so you can't implement it. And then in the outer context are the outside motivators, such as a CMS mandate, or that something is tied to reimbursement. And so there is this outside motivator that pushes for the change to happen. And then what other opportunities might there be for change? Perhaps the health system has a very strong quality improvement team that can actually provide the opportunity to take this outside motivation and mix with the resource changes. And so you see those reinforcing arrows in here. This is a model that's really been very influential in my thinking on implementation science, because I do a lot of work in primary care practices. And over the years of my research, it's been in preventive services. Then the time when we were integrating, we still are, behavioral health into primary care. And now more recently, I'm doing work on really paying attention to the care of patients who have cancer and are in primary care panels. What are we doing with those patients? Are we even aware that they are in our panels? How do we connect with oncologists and other professionals that we need to? What are those care coordination pathways? So that's sort of my current research that I'm pursuing, but really also still guided by this practice change model. This is another one, which is this consolidated framework for implementation research, which folks who do implementation science all know it. It's very popular. It's a meta-synthesis of many theories, models, and frameworks. It is very complicated, but very useful. And if you're interested in thinking about this framework and applying it in your study, I will send you to Dr. Finley and her group, because I'm sure you'll be able to provide the consultation for doing it. But really, it has been tremendously popular in the field and helpful in the field when you want to start thinking about systematic ways to understand your setting and all of the influences that your setting has when you want to implement change. So yeah, having all the guidelines, it will not be enough to improve patient outcomes if we are not implementing consistently. I think that's intuitive and logical, right? And so that's where the field of implementation science perhaps has an answer. So from a definition perspective, implementation science is the study of methods to promote the adoption and integration of evidence-based practices, interventions, guidelines, or policies into routine practice. That's the definition and the vision and the mission of implementation science. And what we think it does is really helps to continue the job of, of clinical and public health research and put it and find strategies and determinants to move all that we know from the evidence into wider practice. And so there is this gap, right, in what we know and what we actually practice. And the hope is that this field of implementation science actually helps bridge this gap. So just clarify a couple of words I've been throwing around here. Evidence-based interventions. These are practices or programs that have been demonstrated to be effective at improving health outcomes, often in randomized controlled trials. Sometimes, and there's a lot written in the literature about what are the levels of evidence, but sometimes it's evidence that comes out of your own practice, or there is evidence that is just conventional wisdom out of many years of practice that you might put in. And we often will have practicing physicians say that, well, this is working in my practice. I'm a big fan of that as well, because you want to combine the evidence that comes from practice also into our thinking beyond the evidence that is generated in research studies through trials. So I just wanted to point that out. And some of the examples of evidence-based interventions are patient navigation, reminder systems, multi-component reminder systems. There's new evidence coming out about shared decision-making approaches and tools, clinical practice guidelines, and there's lots and lots of those kinds of interventions. There is another term called implementation strategies that we use in implementation science quite a bit. And these are methods or techniques to enhance the adoption, implementation, and sustainability of these evidence-based intervention. And examples are you provide some support to clinicians. Practice facilitation is one that's very popularly used. It's a meta strategy. ECHO as a telementoring program has become very popular. Many of you may have heard about that. Changing workflows, providing training. I just put some examples, but there is like a list of implementation strategies that are now compiled, and there's a lot in the literature that we can go to think about which strategies we're interested in working on. I also wanted to kind of highlight where efficacy and effectiveness studies fall vis-a-vis implementation science. So what you'll see in this graph is on the x-axis time, and on the y-axis, the real-world relevance. And so often we start with some pre-interventions work that informs an efficacy study and then an effectiveness study, right? And that's the space where we're kind of interested in asking the question, could a program work? And does the program work? Those are the questions we're asking. And again, we're often using randomized trial approaches to establish these efficacy and effectiveness. But when you get out of those effectiveness study and get into this yellow box here, you are now starting to do these dissemination and implementation studies, where the question really is, how do I make the program work? And then you're focusing on how to get the program or intervention to be better adopted, implemented with fidelity, with effects and penetration across the entire system, and then sustained over time. So inherently in that yellow box of the D&I studies, we have to pay attention to multiple levels of context and social determinants of health. We have to pay attention to external validity, not just the internal validity of the randomized trials. We have to incorporate stakeholder perspectives, and I would almost say that you have to partner with stakeholders to do all of the D&I work. And yeah, that was my last comment, that we have to partner with implementation organization. And what that means is that what is in the foreground and the background in the effectiveness study and the implementation study kind of flips. So in the effectiveness study, what is in the foreground is the intervention that you're trying to demonstrate is efficacious or effective. And what is in the background is how that intervention is implemented in the RCT setting. That system to support the implementation or delivery is sort of a little bit in the background. And what we do is we say it has to be with fidelity. We have these protocols. It's tightly controlled because we're focusing on internal validity. Whereas in implementation research, the intervention itself is in the background because we're using evidence-based interventions. We don't need to reinvent the wheel to prove that it works again. We can go with that assumption that it's already been demonstrated to work in clinical randomized trials. And now we want to focus on the system itself to support adoption, delivery with fidelity. And therefore, the focus is now more on the implementation strategies, how to make the program work, and the implementation outcomes, which I'll tell you in just a minute. So it's really more about that, what's in the foreground, what's in the background, that we kind of are grappling with when we do implementation research. It's multidisciplinary. This is not, I mean, implementation science didn't kind of come out of thin air. Erin and I did not just make it all happen. I think that it's actually more of a coalescing science. It's bringing so many disciplines together when we want to think about our health systems, our providers, our patients. And so, you know, I came from primary care, health services research, how to improve healthcare delivery in the years where implementation science was not a thing, like it wasn't a word. And many of us have these stories like, oh my God, I was doing implementation science and I didn't know I was doing implementation science as the field kind of started coalescing together, which I think is about 25, 30 years that I think it's been around, maybe a little more than that, but really been on the up and up in the last 15 to 20 years with a lot of investment from NIH and leadership from NIH in this space. You'll see quality improvement science, health communication. I think it should have health behavior and intervention development. Many of those fields kind of are merged into implementation science. So very, very multidisciplinary. Our teams are very multidisciplinary. We have epidemiologists, biostatistics, of course, clinicians, sociologists, anthropologists. It's very, very multidisciplinary. All right, so let's kind of jump into this a little bit, into this illuminating the implementation black box. So we're familiar with an intervention, let's evidence-based intervention, colorectal cancer screening, just to have an example. And we're always interested in whether that improves some outcome down the road, right? This is the traditional pathway. And it's often some sort of health status, symptom improvement, satisfaction function, so on. The usual, we're interested in that. I think what is missing and kind of hidden is all this other stuff. How are we going to take that evidence-based intervention, put it into practice? What are those strategies? When you implement those strategies, are those strategies and the intervention, is it feasible to implement? Can it be done with fidelity? Does it penetrate throughout the system? Is it acceptable to providers, acceptable to patients? Can it be sustained? What is the uptake? How much does it cost? And those implementation outcomes are the meat of what we do in implementation science, because we hypothesize, contend, and argue that those outcomes then are related to the downstream service outcomes like efficiency, utilization, patient-centeredness, even equity, and then down to health outcomes, right? So what is in here is this implementation pathway that we've not been really paying attention to in the traditional paradigm of generating evidence and implementing interventions into practice. And implementation science sort of helps kind of bring that together and shed light, and it's creating methods and theories and models and frameworks to really start thinking about that implementation strategy, outcome, service outcome connection, and the mechanisms by which it happens. This is a paper in 2023 in JAMA that really is talking about opportunities for implementation science and research in clinical settings that I encourage you all to read about if you can. And so just summarizing this primer on implementation science, what are the different ways it can help? And I touched on a few of these. It helps identify factors to influence implementation, or pay attention using those determinants framework and collect those data systematically, and often using mixed methods, both qualitative and quantitative. It helps to start thinking about adaptation and tailoring, because what works in one context may not work in another, or will not often work in another context. And so some levels of adaptation are needed if you're implementing an intervention or a clinical practice guideline in a Kaiser or a federally qualified health center or the clinic system here in San Antonio. It definitely is helping in identifying, developing, designing implementation strategies to accelerate adoption, implementation, and sustainment of these interventions. It's also starting to help us think about de-implementation. In clinical practice, we're often using things that where the evidence now does not support the use of those things, or it's just clinical inertia, it's just going on. And in fact, we need to de-implement. A great example of it is cancer screening in individuals older than 85. There isn't consistent evidence, and we still see practice where it's just kind of happening. You know, everybody's getting recommended. So there's a lot of research coming out in many different areas of de-implementation, and also then thinking about dissemination and scale up. And I think that's where I'm very interested in dissemination and scale up, because we do a lot of work in our own little setting, you know, in our nooks, but how can we leverage the learning and not lose the local learning to then be thinking about dissemination and scale up of interventions. So here's my example of the colorectal cancer screening. This is the guideline again, and I bring that figure back of the change in guidelines, improvement in the adherence rate over time. But then if you see this by the federal poverty level, you'll see that the ones that are you know, below the 200%, you see that line down there, the disparity is huge. And then the last figure there are the FQHC, so the percentage of federally qualified health center patients age 50 to 75 who are up to date with CRC screening. And you see that those rates are just about in the 40–45%. It's really, really low. And this is sort of the context or background for our colorectal cancer control program. This is funded by the CDC, is a national program with many awardees, as you see in the map on the right side. And really the goal of this program is to increase colorectal cancer screening in these clinics through sustainable health system change. And so we work with, you know, the CDC, we are one of the grantees, and we develop local partnerships. We do these assessment and implementation and provide support in the clinic to really help implement. I'll tell you a little bit more about that. So I'll jump this slide. So we have four clinic systems and about 16 clinics in this intervention, in this study. And if you see the colorectal cancer screening rates ranges from 6% to 34%. I have so many comments, like, how is it possible that a clinic has 6%? And this is a population with so many needs, and it's such an under resourced setting that we really have to work on capacity building and really getting them to do more. So these are the EBIs, the evidence-based interventions for increasing colorectal cancer screening that have been recommended by the community guide. And I want to say just a few words about the community guide, but you know, I'll be going a little bit in detail on the EBIs, but I'll tell you more about the community guide. So like the US Preventive Services Task Force, there is a Community Preventive Services Task Force. And it does something very similar. It provides recommendations and findings on programs, services, and other interventions to protect and improve population health. And these recommendations and findings are based on systematic reviews of the evidence of effectiveness, economic impact, and they all make up the community guide. Like Dr. Sivat said, it's a group of experts who meet together, review the evidence, and so on and so forth. But the US Preventive Services Task Force and the Community Preventive Services Task Force, they work together. It's complementary. And so if you'll see the settings down, right, the US Preventive Services Task Force tends to have more of a clinical perspective. And it's so that the settings in which it's often relevant, if you may, are primary care offices, health system, community-based organization. And the types of services that they are looking at are screening tests, preventive medications, behavior change counseling, maybe a little bit of the information education. But then the community preventive services task force brings more of that public health perspective. And now we're talking about going beyond the health system, bring the built environment, communities, states, nations even, and also focus on levels beyond the patient and the provider and the health system to the organizational and public policy. And so they work sort of in a complementary fashion to provide guidelines. And so the interventions that come out of the community guide are things that have been developed over many, many years through fields in behavioral interventions and behavioral intervention development that should not be shortchanged. Implementation science sometimes is reinventing the wheel almost, it feels like, and we don't want to shortchange that. There's a huge field of behavioral intervention development that has shown that patient reminders actually work for increasing colorectal cancer screening, especially around the FIT kits or FOBTs and before the FIT kits were done. And why should we ignore this evidence? It has been shown to work, so let's try to implement it. And so in this program we did, and there are many different types of patient reminders one could use based on what works in that setting. Similarly, provider reminders, which are best practice alerts, or that a client is overdue for screening. These kinds of reminders also work, although we know that we're getting fatigue from best practice alerts, and we need to be working on those issues as well. Reducing structural barriers is another evidence-based intervention from the community guide that we're implementing in the colorectal cancer project that focus on things like modifying the hours of service to meet the client-patient needs, perhaps considering mailed fit kind of approaches, providing deep dependent care. And we're really doing a lot of work in saying that childcare is itself a social determinant of healthcare, and what can health systems be doing to support that? Transportation, translation services, those kinds of things. Clinician assessment and feedback, or audit and feedback, is another evidence-based intervention that's recommended and that it works. And this is another one that is part of the colorectal cancer program. And so going back to the evidence-based intervention and the implementation strategies, the EBIs are ones that maybe a clinic or a system may say, okay, we're going to do patient reminders, and they have the organizational support to do that and implement it and roll it out. And they're probably using some strategies, but those strategies are not seen or not described well. But when we do research studies like this one, we are helping develop the strategies to get those interventions into practice for these FQHCs because they don't have the capacity to do that. And the strategies might be one strategy, just discrete, or often a multifaceted implementation strategy bundle. And some of the methods, there are many methods we can be using for designing and tailoring implementation strategies. In this project, we used something called implementation mapping, which takes implementation science principles with this process of intervention mapping to then help develop the strategies. And I won't go into much detail, but it's a 5-step process. And very simply what it is who are the adopters and implementers of the intervention? What do they need to implement it, and why do they need to implement it? What are the determinants? How should they do it? Where the strategies come in. And we always want to do it grounded in theories and frameworks. Develop these implementation protocols and materials so there is like an implementation blueprint that clinics can use, and then evaluate, is it working? So that's sort of the 5-step, very intuitive process of implementation mapping. And so we did a organizational needs and readiness assessment for all of these health clinic systems, where we focused a lot on, are they ready to implement? And we, in the literature, are leaders in this space, conceptualizing readiness in this form of R equals MC square, which is a heuristic to say readiness is a combination of motivation, the general capacity of a system, And then innovation-specific capacity, what are they interested in? Do they have the capacity to do the screening or do the whatever innovation that we want to do? And you'll see that the organizational needs assessment, which we did using a multi-method approach, is multifaceted, that focuses on the use of the EBI, what supports are needed, what data systems the clinics have, what types of EHR and what optimization is needed, and what are the clinical workflows. So it's sort of multifaceted. And then we identify those adopters and implementers in a very systematic way, develop the implementation strategies, and I will not go into details of this figure, but this is kind of behind the scenes work that us implementation scientists are doing to then support the clinic in actually using implementing the guideline. These are the strategies we came up with, this complicated, time-consuming, but systematic process, working closely with our clinic partners that we said are needed to get those evidence-based interventions, the patient provider reminders, the assessment feedback into practice. And that became a technical assistance package that we then provide as external support to the clinics. That also includes identifying clinical champions, optimizing the EHR, and we have a team that helps do that. Optimizing EHRs for all kinds of different innovations are such a huge barrier, just nationally. In almost every study I've done, it's like the first barrier that people bring up is EHR. We really need to make this easier. And practice facilitation, this is the process that we undertook. There are some goals around creating an improvement team in the clinic, training them in a few quality improvement techniques. We've been actually very fortunate that our clinics often in FQHCs will always have a quality improvement person. So there is some capacity already there. And then with that team, we kind of in a participatory way, identify to overcome barriers and then build capacity to increase colorectal cancer screening. One of the strategies is also Project ECHO, where all these clinics come together monthly to discuss specific cases around what challenges they are experiencing. And also there is a didactic component that our team provides of experts who can talk on any of the different aspects of it. So, in the interest of time, I'm going to jump through these slides really. What I was trying to provide here is that on the ground, we found real barriers that needed very contextually relevant solutions. These aren't solutions that just are in the literature. It's like understanding what are your problems and then maybe leveraging the literatures, but really coming up with some of these solutions. And so what I have put here for each of the EBI is this immense amount of work that goes into supporting these clinics and coming up with solutions that will have buy-in from the clinics and will therefore want to be implemented, adopted, and sustained. So again, that participatory process of doing it. And it's not always successful because, you know, the barriers like they don't have staff. You have to give them a little space and come back and stay connected. And, you know, it's hard work, but I think it's needed. So this is one of the FQHC systems that implemented patient and provider system. And over these 2.5 years has made some good progress with the implementation of these EBIs and supported by the strategies that we came up with. I mean, I'll right off the bat say this is not a clinical trial. We don't have a control group. But that's not the intention of the CDC colorectal cancer. It's a demonstration project where this is what we're doing. And what we bring to the table is that evaluation. What can we learn from these 4 systems and 16 clinics that then can also help other FQHCs nationally? So that's the scale-up part of things. The goal of this clinic was 37%. They're setting realistic goals. They know they're not going to get to healthy people 2030 goals in this 5-year project. And so we hope we can renew and continue the partnership with these clinics. This is a second clinic that also made good progress for a couple of years, but then the guideline changed. The denominator now includes patients who are 45 and over and not 50 and over. And we're now working with them to see if we can get them to stratify their denominator by those who are 45 to 85 and 50 to 85. So they can see the progress they are making in a way that it's apples to apples versus what is happening here, where it looks like in 2023, their rate went down. The real challenge on the ground. And I've seen this happen in many other projects where, you know, the CMS metrics and the way EHRs are designed and produce these metrics do not allow for the nuances of saying, well, I want to actually see a 6-month rate so that I can have a sensitive measure for change. No, I can only see a 1-year calendar, you know, so the people who work in that space know that. And these are real issues that require the research and clinical partnership. And not to just bore you with more models, but this is the reality. The model for improving colorectal cancer from the CDC, screening from the CDC, this is on their website, and you'll see that you have to be paying attention to so many levels beyond just the individual patient. It's the interpersonal, the organizational, the community, and all the influences that go around it. I wanted to introduce the idea of the implementation research logic model for those who are interested, but I won't go in detail, but this is the systematic way in which we can start thinking about it. So for example, we're interested in improving colorectal cancer screening all the way to the right side. And, you know, we know that it'll help reduce mortality and morbidity. But we know that there are some factors, determinants. Do we have the right quality improvement support? Are there EHR challenges? Are the clinics busy? Is there a mandate? Are the clinical leaders motivated? And so we study these factors and we say, well, these interventions exist like a clinician best practice alert or a shared decision-making tool or a patient reminder. And so let's work with the practicing clinicians to say, or the health system leaders to say, what is the implementation strategy bundle that's needed? And maybe here are some of the strategies that the group may come up with that is relevant to their context. And I didn't put anything in the mechanisms because the mechanisms are the ones that through evaluation, we kind of understand and learn a little bit. So in summary, implementation science uses synergistic tools and processes that can be leveraged to improve the implementation of EBIs. It helps to start thinking about tailoring those evidence-based interventions. We want to ensure that our strategies developed or selected really address key barriers to adoption, implementation, and sustainment. We want to create a learning community that discusses these challenges and successes, can help everyone advance their work to improve colorectal cancer screening and other practice improvement. And that's kind of how we're leveraging implementation science in this CDC colorectal project. I'll put a plug in for something that's very close to my heart. In the clinical health system setup, quality improvement is a known entity. Everybody knows quality improvement. And sometimes we're dissing it like, okay, now implementation science has come around and what is quality improvement? And I really make a case for blending the two to improve outcomes. And what I'll show you is this, where implementation science, if you see on the right side where it says start, it really brings information, details about EBIs and programs, theories, so that it is based in knowledge and theory of evaluation and these systematic processes that I described. But quality improvement brings this process of interaction that honors the lived experience and expertise. It has this hyper focus on local context, which we need, and helps the methods allow to align the intervention and competing priority based on that setting. And we need that. We cannot do our work without that. The problem is that many of these quality improvement cycles and what is learned from that is lost when that knowledge is lost. We lose what is working, what is not working, because it doesn't ever get written up or often does not get written up. And so then again, implementation science brings the rigorous analysis of outcomes, focusing on contextually specific strategies, dissemination efforts, and this idea of generalizability, and kind of closes the loop for us a little bit. It's complicated, but I think it makes sense. And I'll stop that. I have a couple examples of another project that I did, and I'll end with, these couple of quotes that I think kind of drives me to do this crazy work, which is a little knowledge that acts is worth infinitely more than much knowledge that is idle. And also that, to someone who devotes their life to science, nothing can give more happiness than increasing the number of discoveries, of course. But really the joy is when the results of those studies find practical applications. And as a practicing physician in a previous life and a researcher in this life, this really speaks to me. I managed to get the slide in about our institute and the seminar series that's coming up. We encourage you all to attend. I think if you're interested, I just put a snapshot of the seminar series and speakers from last year, and it was very well attended, and our evaluations were excellent. And I really hope that we can continue to advance this work to bridge the gap between what we know and what we practice. And with that, I'll take questions and discussions.
I really enjoyed that a lot, and particularly the last couple of slides where you're trying to tie implementation science and quality improvement, because throughout the talk it was like, these two really go hand in hand. And so what I'm sort of asking about is the implementation of implementation, and that, how do you see like an implementation scientist actually kind of getting things implemented on the ground versus studying implementation strategies? And so it's like the doing of implementation versus the study of implementation.
Yes.
And are there people, and how should we take this forward, like as institutions, to have like every quality improvement sort of office in a hospital or something should have somebody who's basically trained in implementation science, that maybe is not doing research in that, but is actually just practically applying those principles?
No, excellent question, and so close to my heart. What I would say is that in our clinical practice settings, especially in the large health systems, academic health systems and integrated health systems, especially in those, but perhaps in every one of them, I've been toying with the idea of embedded implementation scholars. I think that kind of a person who's embedded in it, not coming from the outside saying, I have this ivory tower research question I want, and now I want you guys to participate as a research participant, but they're embedded, they see the challenges, and they have the knowledge of implementation science and quality improvement and all those multidisciplinary fields. Or I would even say an embedded team. And that then makes the implementation efforts, not science, it may be quality improvement, right, more systematic. The lessons learned can be applied even within the same system. So, it's so unfortunate that because of our funding mechanisms, we do work in silos of disease areas, but no patient is one disease. Patient is, right, a person. And so something that works in diabetes could also work in other chronic conditions. And we are not connecting the dots because the research is coming sort of from the outside. Quality improvement is also sort of driven by metrics, right? What metric do we want to improve? Because, well, somebody in the policy world told us we need to improve it. But if it is more organic, we want to provide better care to our patients. Yes, the policy environment, the funding and reimbursement environment needs to be taken into account. But I think implementation science is giving us the tools to do that. But we need to have those embedded scholars and teams. So that's one maybe approach or answer to your question. I think the other one, which is the implementation of implementation, that's really nicely put, is that, and I will admit that the field of implementation science is grappling with this issue. And this has come up in our recent conversations and in conferences, that we are becoming a research enterprise like any other research enterprise, and are losing track of this bridge that we need to build. And to build that bridge, we inherently have to stay focused on practice. I come from a space where Lawrence W. Green, many years ago said, if you want evidence-based practice, you need practice-based evidence. And I think the evidence that's generated from real-world practices trying to implement anything are lessons learned and lost, unfortunately, that we need to bring back. And doing that is, so that's, sometimes I feel that's a somewhat idealistic, naive answer, because where's the funding going to come from? And the funding comes from NIH dollars or clinical dollars. And we need facilitative leaders who are ready to be creative in creating that funding strategy to have those embedded scholar teams. And I think that it can be done. It's really a lens, you know, we kind of shift the lens a little bit. So
are there training programs for these?
There are. Thank goodness. There are more and more now. There aren't enough implementation scientists well-trained out there for us to recruit, as we all know, but they are, there is more and more of that happening now, yes. In fact, at our institution, in our School of Public Health, we have introduced a certificate in dissemination and implementation research that can be added on to some of those public health programs, maybe somebody in epidemiology or in behavioral science. So at least they get a primer on it, and then they can continue to go from there. Yeah.
That was excellent. Where do you think behavioral economics fits in either your models or various models, both at the patient level, to say incentivize patients to get correct cancer screening financially or otherwise? And at the health systems level, we have value-based healthcare, which is a financial incentive, but where do you think that fits in?
Yeah. So the question, I don't know if folks can hear the question. The question is, where does behavioral economics fit in implementation science? I'm seeing a growing literature on behavioral economics as an implementation strategy, in the way I defined it, to increase the uptake of clinical uptake of evidence-based interventions. And some of the literature I'm actually familiar with through some other project is in the HIV/AIDS space, where they are using behavioral economic strategies, nudges, and those kinds of things to get patients to be on PrEP or use it even at a provider level to do that. So the literature is emerging in that space. Well, what I will add to that is something I did not touch on here, which is in implementation science, the idea of type 3 studies or approaches that are focused on testing the effectiveness of strategies such as behavioral economics. And those should give us better evidence that if you're interested in screening or if you're interested in HIV, how well is behavioral economics approaches working or not? So those are sort of the type 3 strategy interventions that are coming out in that space.
Questions in the chat.
There is one question in the chat. Do you want me to take it? Okay. There's a question, how does implementation work in a disease like Alzheimer's, where there is evidence, in quotes, from randomized control trials, but the disease is still progressive and implementation involves patients with diminishing capacity and also their caregivers? And that's a great question. I don't know if I have a great answer for it, but I think one of the things that implementation science does is allows us to look at levels beyond just the patient. So patient, the caregiver, and the caregiver may be a spouse, may not be a spouse, but it's that team. And we need to go in and think about what is that relevant group that we can be working with. Are these patients in different kinds of settings? Maybe they're home-based, they're in nursing home settings. What are the characteristics of those settings that we need to understand better before we even jump into thinking about implementation? And the disease being progressive, I don't know, maybe a clinician can jump in and answer, but I just right top of my head, I'm not seeing why that is as critical in thinking about getting the evidence to the patients. But the challenge may be like what somebody brought up, that the evidence might be changing rapidly. There are new therapies that are available in Alzheimer's that we need sort of rapid implementation. And in this case, what I didn't talk much about, dissemination of that new evidence quickly into the hands of clinicians. So even I know that was not a very satisfactory answer, but I tried.
Good question. I think a lot of people mentioned time as a significant barrier. And it seemed like CMS tried to address that by coming up with a wellness visit for Medicare beneficiaries, where really your sole purpose in that visit is to talk about, to do some screenings and talk about preventive health care. In our experience, the uptake on that has been spotty, and adherence to any, we make a nice detailed list of recommendations, but sort of completion of those is not, isn't what we would hope, right? So I don't know if you know of any form, that's my sort of downtown clinic experience, but I don't know if anyone has looked at the efficacy of the wellness visit in completing preventive screening. Because I feel like that's what we all say is I just need more time to talk to my patients,
Yeah.
I know in our case, it could be because we don't necessarily have the PCPs doing the visits. We have nurse practitioners. So I don't know. I think some of the time benefit is me, that I know you, I've worked with you for 5 years, and it's me telling you how important this is versus this person assigned to do your wellness visit with you. So I just think that's interesting because yes, if you would have asked me, I would have said, I just need more time to talk about all of these things. But I feel like that was a mechanism in which we did get, Medicare pays pretty generously, right, for you to sit and talk with patients. But I guess I just wonder out loud, why has it not really had the benefit that we would want?
Yeah, one is it takes time for the benefits to accrue. But maybe I'll shed light on one project that I was involved in. It was called the My Own Health Report study. And it actually, and there are lots of papers from that study in the literature, and it actually worked. It was in the wellness visit, sorry. And it was about creating an opportunity where patients, before they come to the clinic or in the waiting room, fill out a assessment tool on a tablet, and the data goes directly into a goal setting document. And so at that point, the clinician gets the goal setting document and can say which things are the patients ready to work on, because they're not going to be able to work on everything. And when that was done, actually goal setting improved. It reached a lot of patients. It was done in diverse types of clinics. So there might, in those papers in the literature, you might glean some more stuff. We can talk a little bit more about that. But that's one intervention with built-in strategies that actually did work. But that's really from my experience in that project. I'm sure there might be other things.
Great, thank you.